I have a question to be asked. How successful is the endodontic treatment? I want it to be more interactive rather than one-sided program.
If performed properly,
yes, sir.
With the proper stepwise protocol being followed, more than 80-90%.
Yeah. So according to American Association of Endodontics, they say the success rate of endodontics is almost 89 to 94%. This again, it is from a resource called as American Association of Endodontics, that is the pioneer in endodontics. The second question I have to ask is how long it will stay inside your oral cavity. If I am going to do a root canal today, how long it will stay inside the oral cavity? So all these are the questions which is asked by the patient to you, right? How long it will stay inside the oral cavity?
Almost lifelong.
Yeah. Lifelong? Depending on how you are going to treat and depending on the case selection and the follow-up, it should stay inside the oral cavity for minimal 8 years time. If you are going to follow all the protocol, it should stay inside the oral cavity for 8 years time. And this was a study which was done long back in 2004, which they have confirmed that the teeth survived inside the cavity. Probably they have done a treatment for 100 teeth. Of that, 97 tooth survived inside the oral cavity for at least minimum 8 years time. Probably another 3% is insignificant, probably because of improper follow-up or probably over a period of time any systemic disease would have happened for that patient. Yeah. Yeah. So success depends on not only just doing an endodontic procedure, it also depends on post-endo, right? So it is almost like hand in hand. Which flag is that?
Russia.
Yeah. So it is a hand-in-hand procedure, or if it is just endo, if you are doing a good endo, that doesn't matter, it won't survive if you are not doing a proper post-endo. Yeah. So if you do a root canal with a small access cavity, the stability or the stiffness reduces by 5%. If it is like a MO or a DO cavity, the stiffness reduces by 20%. 20%, and if it is a MOD cavity, the stiffness reduces by 63%. So that means if you are not doing a proper post-endodontic restoration, it is going to fade within a short period of time. Yeah. So that is why the topic name is restodontics. So we are just going to cover, predictable endodontic procedure, how to do a predictable endodontic procedure and a post-endodontic procedure. This is what we are going to see, and it is purely experience-based presentation. There is no theory in it. It's purely experience which I have gathered over a period of time. So this is another study which has shown that if you are doing a good endo and a good post-endo, the survivability of the tooth is almost 91.4%. And if you are doing a poor endo, but your post-endo is good enough, it should survive for about probably the percentage of survivability is 67%. And if your post-endo as well as the endo procedure is going to be poor, it will be almost 16%. Yeah. So that doesn't mean that if you have to do a bad endo and good prosto. For me, even if I do a bad endo, my wife, she is there. She is a prosthodontist. She will take care of the post endo. So I'm very happy in that. Yeah. Key to success. I have a dental clinic. Yeah. I have a dental clinic which is having a good infrastructure, and I'm a good skilled person, or my clinicians or my specialists are very skilled, but I don't have a good lab to support. So the result is going to be bad. Yeah. So similarly, key to success depends on your case selection. So if your case selection is going to be bad, definitely the success rate is also going to be down. So we'll see what are the factors affecting the case selection. That is periodontally, if it is weakened. As you know, we can do a root canal for that once we extract. Yeah. But inside the oral cavity, if you do a root canal, definitely it will come out. Endodontically, if it is completely calcified, that means naturally it is totally obturated. That is, God itself has obturated it. So if it is completely obturated or if it is completely blocked, no need to touch that. If it is the patient is not having any symptoms. Yeah. Restoratively, if it is not restorable, if the furcation is involved, don't touch that. So mainly endodontically, if it is completely calcified. I have an experience that one patient came, she is 67 years old, and she came with a anterior proclination, and she wanted to be corrected. So only option, I cannot go for an orthodontic alignment because she is 67 years old, and I did intentional root canal for that tooth. So I was overconfident that I didn't take an X-ray because being around 5-10 years of experience, I thought, okay, just an anterior, easy PC, just go for an axis. So I just did an axis opening, and I couldn't locate the canal. So I was like, first sitting, I couldn't locate the canal. So I thought it was canine to canine. Yeah. So I just opened like that, and finally I couldn't find the canal. It hit my ego. எனக்கே கண்டுபிடிக்க முடியல அப்படின்னு ஒரு ஈகோ ஹிட் ஆயிடுச்சு. Next visit I again called the patient. I couldn't locate the canal. Third sitting, I sent the patient for CBCT, and we have found that it's completely calcified. Yeah. So then I took X-ray for all the teeth. Everything is calcified. Patient is not having any symptoms. It's all intentional root canal. Then I went back and asked the history of the patient, and she told I had a surgery for kidney stones. So probably 6 or 7 years back, and it was severe, and I underwent a surgery for that. And then I went back to the literature, and when I compared with your pathological calcification and dental stone, there is a correlation. Yeah. So dental history or your medical history is very important before jumping into any kind of treatment. Yeah. Occlusion, as we have already spoken, madam already covered that topic. Occlusion, the occlusion is not proper, that has to be adjusted, or it has to be taken care. Anatomically, if it is very close to the tooth, anatomically if it is very close to any inferior nerve or your sinus, you have to be very careful while using mainly bioceramic or MTA or any kind of injectable kind of gutta-perca. You have to be very careful because that can go inside the inferior nerve, and that will result in compression pain, or post-operative pain will be severe. Isolation is a must. So I can just tell a lot about isolation. Whether I am following that, till COVID I was not following that. Post-COVID I have been trying to introduce rubber dam isolation in my practice. Not for every other case, but I am trying maximum. So in your practice, try to introduce rubber dam isolation. It brings a lot of change in your post-operative outcome. Yeah. Compromised axis, again, definitely you can do root canal for 8 also or 7, but if there is compromised axis, try not to do it. Yeah. Try to give a muscle relaxant to call the patient next sitting, and you can try. Motivation for the patient, as we have already discussed in first itself, sir would have told, if the patient is not motivated or he is not ready to do a root canal, don't push them to do it. And finally, 9th is the capability of ourselves. We are not capable, try to send that patient to somebody else who is capable enough or achieve that capability. You have to, over a period of time, achieve that skill. So these are the factors which has to be considered. So these are all my cases which I feel it is all Instagram looking, wow looking observation. It is not possible in every other case. Probably என்னோட ஒரு 100 கேஸ்ல இருந்த நல்லா இருக்கிற கேசஸ் I am going to put in this slide. Yeah. So all we need is such kind of good looking, wow looking observations, right? This is what we need. The end result should be wow. So it should not be the beauty, it should be about, it's not always about looks. எல்லாருக்கும் பார்க்கிறது looks தான். Final observation super இருக்கா இல்லையா, but we are not following the objectives. So these are the objectives which has to be achieved before doing, or instead of comparing with the X-ray. So these are the objectives. One is finding all the canals, getting down the canal, establishing the working length, gauging and enlarging the apical diameter, disinfect the remaining space, and finally obturate. I think all these things you have been following and doing it, but I am just going to cover in such a such a manner that it becomes more predictable, right? Finding all the canals, definitely we have to have all the armamentarium. Definitely by this time you will be knowing the anatomy and the morphology, right? Molar gevlo, lower molar gevlo, canals irukno, upper molar gevlo, canals irukno, what is the anatomy, where to do the axis, all these things you will be knowing as a starter. And definitely main thing is patience. That doesn't mean that you have to make the patient sit for 2 hours to just do an axis opening. Yeah. So coming to armamentarium, all the armamentarium what we are using, it is all like a weapon. Weapon means definitely it can hurt somebody. If you are not properly doing, you are going to hurt somebody else. So you are using weapons. So basically all the sets of instrument we have to have. From Moni they have something like a small round bird that starts from BR. Is it visible? Visible? This is BR31, BR40. As the number increases, size of the burst becomes smaller. Yeah. If you are a starter, if you are a beginner, start with the round burr just to do an axis, just to do something called as a troughing. What do you mean by troughing? Don't directly drill the tooth. You have to do something like a small trough. Trough means a class 1 madri, so troughing panni, then go deeper and deeper. Don't directly drill inside. Okay. So for that you can use a round burr. Then you can use something called EX24. Once you get the drop means once you open up the roof of the pulp chamber, then in order to remove the roof of the pulp chamber completely, you can use something called as a non-end cutting burr. Non-end cutting burr, right? EX24 in Solonga, Manilirundu. And they have something called as end to axis burrs. If you are a starter or a beginner, I will suggest you not to use this. Start with a round burr and then go with a non-end cutting burr. Even if you touch the floor of the pulp chamber, you won't end up in perforation, right? So once you get experience with these burrs, then you can try with an endo-axis burrs. They have MI burrs, that is a stainless steel carbide burrs are also available. If you are into something like biomimetic restoration, or if you are trying something like deep margin elevation, you want to just remove the caries alone, in such cases you can use these carbide burrs. Okay. If you use a diamond burr, there will be a lot of cutting, whereas these carbide burr, it won't remove too much of dentin, it will just remove the infected dentin alone. So that is the difference between your diamond burr and a carbide burr. It is available from Moni. And I use these kind of ultrasonic tips. It is basically from Satellite. So there are different numbers. Basically, what is the use of this ultrasonic tip? It is basically to remove the calcified structure. Once you do a axis opening, normally calcification happens from coronal aspect to the apical portion, not from apex to the coronal portion. So coronally, if it is calcified, you can just remove the calcified structure from the chamber using these ultrasonic tips. This is basically to remove any calcified inside the canal or instrument separation. All these things can be done using these kind of ultrasonic tips. This is basically from Satellite. So this is again using a normal ultrasonic tip. நம்ம scalar tip use பண்ணுவோம் பாத்தீங்க, அதோட sharp tips can be used just to enlarge the orifice. Yeah, enlarge the orifice. So most potent weapon which Abdul Kalam ji has introduced, what is that? In dentistry. Abdul Kalam ji introduced பண்ணது Prithvi Agni சொல்ற most potent weapon we have. But dentistry per se, what is the most potent weapon, or endodontic per se, what is the most potent weapon? It is your sodium hypochlorite. So if you are not using sodium hypochlorite, you are not doing a proper endo. Even I think, doctor, I think you will also tell that sodium hypochlorite, without sodium hypochlorite, even pediatric endodontic is not possible. In order to remove the pulp tissue or microorganism completely, you have to use sodium hypochlorite. That is the gold standard right now which is available. Probably over a period, there are different types of newer irrigants which are going to be introduced. It is not available right now in India, but gold standard and economically available irrigant, best irrigant, gold standard is always your sodium hypochlorite. So these are the different irrigants. As you know, you have to use sodium hypochlorite, your hydrogen peroxide, your EDTA. All these are available. These are the different new irrigants which is going to be introduced. It's called as Triton. So just the irrigant cannot travel inside the canal. Irrigant mattu use panana, the canal kulla it cannot travel because of capillary effect. It won't travel inside the canal. For that you have to have different devices. So what I use is ultrasonic and sonic devices. Ultrasonic tips, which is available from woodpecker as well as satellite. Woodpecker is cost efficient, and if you are, and sonic agitators, these are called as sonic agitators, is basically plastic tips. What is the difference between ultrasonic and sonic padasna? Ultrasonic padasna metal lo and sonic padasna plastic lo. Okay, so this is basically to agitate the irrigant. What do you mean by agitation and activation? Agitation means push the irrigant inside the canal. Okay, activation means it increases the efficiency. So for that you can use sonic and ultrasonic. If I don't have that, what can be done? You can just heat the irrigant. Your sodium hypochlorite can be slightly warmed. That will increase the efficiency, and then you can use a normal GP or your normal K file to agitate the irrigant inside the canal. Okay. So this is just a tip. These are the ultrasonic tip. There is a continuous irrigant. So that is called as CUI. That is continuous ultrasonic irrigation, and this is passive. The next one is passive ultrasonic irrigation, where the irrigant is not continuously irrigated inside or moved inside the canal. Yeah, got it? In continuous ultrasonic irrigation, continuously irrigant will be passed out when you are using ultrasonic tip, and passive ultrasonic irrigation, where you will be just putting 2 or 3 drops of irrigant inside the canal and use the ultrasonic tip. Got it? So loops and microscope, I have not introduced initially in my practice. Over a period of time, I started using loops as well as microscope. If you want to do a precise work, definitely loops will be better, and then over a period of time you can use your microscopes. Coming to anatomy and morphology, you have to take 2 X-rays before starting an axis opening preparation. 2 X-rays is must. One is to measure the full length, that is called as the tentative working length, and the second one is to measure the from the roof of the pulp chamber to the coronal portion, right? And there are, different types of axis cavity preparations. Yeah, the most predictable one is normal axis cavity or conventional axis cavity preparation. Other than that, from 2010 they have tried to use or do different types of axis, where the small axis cavity preparation or ultra small axis cavity preparation, for all these things we have to have loops of microscope. So it's a very small axis, or something called as truss axis cavity. Have you heard about that? Truss axis cavity, that means just the axis in the mesial and the distal side, and they will inside, we can introduce the file inside the canal and remove all the pulp tissue and obturate. So all different types of axis cavity is there, but of that the best one or most predictable one is your conventional axis cavity preparation or conservative axis cavity preparation, where you can see all the canals visibly, right? So best one is teachable, repeatable and predictable one. That is the best axis cavity preparation. Don't try with, already we are having the dentistry itself is complicated. Don't complicate more by doing a small axis cavity preparation just to show off. Don't try that. Okay. So just to brief that, why we want to have a conservative axis? Conservative preserve this structure. What is that structure called as? Pericervical dentin. What is pericervical dentin? The structure 4 mm above from the CJ and 4 mm below from the CJ is called as your pericervical dentin or PCD. So in order to preserve that structure, we have to do a small axis cavity preparation. Iatrogenically, don't remove too much of tooth structure. If there is any decay, yes, definitely you have to remove that, but iatrogenically don't remove that axis, so too much of tooth structure. For that only you have to use a smaller round burrs or non-end cutting burrs. Okay, so this is again just to show off. Even I know to do a axis cavity, truss axis cavity in சொல்றது காட்டுறதுக்காக தான் I'm just doing it. The where axis is done in the mesial side and the distal side, I instrumented, but whether it is predictable, I don't know, because I am not directly seeing what is happening here. I am not very sure whether the pulp tissue is completely removed, even if I have used the best ultrasonic tip to remove all the tissues from this area, but it is predictable or not, I don't know. Probably I have done 3 or 4 years back. There is no follow-up for this case. It is mandatory that you have to have a proper follow-up. Yeah. So predictability is questionable. It's questionable with these kind of axis cavity preparation. Another axis cavity, which is very small axis cavity, is almost like your rubber stopper, can be used to cover this area. That much small axis cavity preparation. Again, this cannot be done using your naked eye. You have to use microscope or loops to do it. Right? So again, your predictability is questionable. So we have found the canal. Right now we have found the canal. We have located the canal. Now what next? This next stage is called as getting down the canal. So your file as well as your irrigant or the irrigation device will be traveling inside the canal like this. There will be ups and downs, there will be twists and turns inside the canal, and finally it will end up till the root end. So this process is called as your glide path. ஒரு pathway create பண்றது தான் நம்ம பண்ண போறோம். Okay. So in order to achieve that glide path, you have to have these control steps. In order to create that glide path, you have to have these 4 control steps. That is opening the orifice, your apical patency, glide path, and recapitulation. Opening the orifice, it is a continuation process of axis cavity preparation. So that means what? It's a continuation process. Asking question is easy. Answer பண்றது எனக்கு தெரிஞ்சிட்டு நான் உங்களுக்கு கேக்குறேன். It is a continuation process of axis cavity. That means the orifice opening has to be done using a rotary instrument. Okay? Why we do a orifice opening? What is the idea behind doing a orifice opening? Yeah, because mainly the amount of pulp tissue, the highest amount of pulp tissue will be inside your pulp chamber. Next will be your orifice. So in order to remove the pulp tissue completely and the interference has to be completely removed, to remove that you have to use a orifice opener to do it. So earlier, yeah, so this is a structure which has to be removed. This is called as a dentinal lip, which has to be removed so that we can have a proper direct access. So earlier times, when I was doing my post-graduation and graduation time, we used something called as a gate splitter. Right now we are not doing that, because what happens when you use a gate splitter? When you use a gate splitter, there will be enlargement of this pericervical dentin, and too much of tooth structure will be removed at that area, and your pericervical dentin becomes thinner and the predictability becomes down. So in Moni they have something called as an orifice opener, separate orifice opener. Almost every company they give separate orifice opener. In Moni they have an orifice opener which is having a length, the working length is almost 9 millimeter. The working portion is 9 millimeter, and the tip diameter is 0.25 and a taper of 14. What do you mean by that? Tip diameter 0.25 and 14% taper.
For every 1 millimeter there is.
Yeah, every 1 millimeter there will be increased by 14. For 0.25 D1 will be 0.25 plus 0.14. So likewise it will increase. Okay. So at your D9 the diameter will be almost 1.37. That is almost equal to that of using a 5 size gate splitter, right? Okay. Coming to tips and tricks, file advancement rule and so on. If your file is moving, it should be advancing. The file is moving, it should be advancing. Sometimes what happens when you do a file move agite irukum, but it won't be advancing inside the canal. What will happen if you keep on doing that? Yeah, either instrument separation or there will be ledge creation. Okay, so if the file is moving, it should be advancing. If it is not advancing, take the file back, irrigate, again do some flaring, or you can just go for a smaller size file and instrument. Got it? File angulation. File should be angulated in an opposite direction. So if you are using the file inside the palatal canal, it has to be inserted from the mesial or buccal aspect. It should be from the opposite direction. Got it? So these are the rules. So now we have enlarged the orifice. Axis opening has been done. We have removed all the pulp tissue from inside the pulp chamber. Orifice has been enlarged. Now the orifice is like this, right? Now you have to assess the difficulty level. So, or it can be also called as canal width assessment. Okay, canal width assessment. So normally we use K5 to assess that difficulty, and that too 10 size K5. So if you ask